Welcome to the Sparked Standards in Action Showcase, where active Sparked community implementers share their perspectives, experiences, and example implementations of some of the fire implementation guides designed by the Sparked community. Here we will have community representatives showing the art of what's possible using the community design specifications to enable safer, more connected, and more efficient healthcare. I'm your host, Michael Hosking, Deputy Lead for Community and Engagement for Sparked. For this showcase, we'll jump straight into the discussion. For a background on Sparked, what it is, our goals, and related resources, please visit sparked.csiro.au. Today, we're joined by Tim and Sanjeet from MediRecords. Tim is a health leader and published author known for blending storytelling with a passion for implementing healthcare through technology. He brings deep experience in business development and a unique ability to make complex ideas accessible and engaging. Sanjeet is a digital health technologist and product leader known for driving innovation in healthcare interoperability. A key contributor to FHIR adoption and SmartForms integration, he focuses on engaging clinical workflows and data exchange to improve patient care. And today we're going to discuss the, challenges around health information exchange in the current ecosystem, how Sparked aims to overcome these, and why MediRecords are involved and what standards they're implementing from the Sparked FHIR implementation guides. Show us what that looks like in the context of a demo. And finally, we'll talk about why other people should be involved. Thanks, Tim and Sanjeet, for joining us, and we're looking forward to chatting about what you've been able to achieve.
Thanks for inviting us. Okay.
Thanks, Michael. Thanks for having us.
So, without further ado, what are your current challenges in terms of health information sharing in the current ecosystem in Australia?
I guess we've got a couple of different hats we wear on the challenges. And so for starters, we're all healthcare consumers. And, there are incidents daily that remind us that gaps in information sharing, say from GP to GP or GP to hospital or allied health, those sorts of gaps in information can have life-changing consequences. And so I know of examples. I was talking to a company today, and they were saying about how patients being discharged from hospital, they don't have any visibility around the medications that have been dispensed in the hospital versus when they get back to the GP. And sometimes medications can be then prescribed that have interactions and can cause safety risks. And so this has been known outcomes. So those sorts of pieces. I've heard of fax machines results coming out of the machine and falling onto the floor and going under the filing cabinet and never being seen again. So, systems that don't talk to each other in efficient ways create risk.
Tim, I have an example. My daughter broke her arm last year. We went to the urgent care clinic and they effectively faxed a reference to hospital. The number was wrong. The hospital never even received the fax. So just an example, which I've faced. So.
Yeah. And then as a vendor organization as well, there are challenges for us. So we've missed out on contracts because we've been asked to integrate with systems that are years behind FHIR. Because we're an early adopter with FHIR, we see that as future-proofing what we're building. We want to be working with other organizations that have taken that same approach, and yet a big chunk of Australian healthcare isn't quite there yet. And so that can be limiting for us from an economic point of view. Otherwise, there are challenges around things like patient matching. There's inefficiencies for healthcare from, if the local hospital in rural Victoria where my dad goes doesn't know that his GP's already ordered x-rays or pathology, the same things get ordered twice. The differences between things like Tim and Timothy or Matt and Matthew or Nick and Nicholas, depending what your actual name is on your patient file, can create all sorts of grief as well. So there's these simple things in sharing data in real time that are just causing challenges every day. And so this is where there's a great leadership opportunity for the Sparked community and for government that's watching to really kind of set out what the standards will be and then perhaps enforce them as well from a point of view of making forward-thinking data sharing part of procurements and funding for healthcare.
Yeah, absolutely. I think you're right. And in terms of coming back to the Sparked community, what problem do you think Sparked solves from your perspective?
I mean, the real magic from my point of view on the Spark community is that you've got all the key players in the one room. And so you've got clinicians, you've got government, you've got data scientists, vendors, laboratories, hospitals, and really importantly, you've actually got consumers in the room as well. And they're talking about how to bring the pieces together that make sense from all their points of view. And that, the end outcome hopefully will be that we're all singing from the same songbook and hopefully in harmony, that we agree on how information needs to be delivered. And so, again, MediRecords has been kind of part of working with Fire for some time, even before Sparked came along. But the other really massive benefit of joining a community is now we get to learn from the community, we get to be part of the conversation, we get to influence the conversation and share information as the community grows. So learning and sharing is invaluable.
And is there an example of where you feel that that consensus level approach has accelerated your process or progress?
Sanjeev?
Yeah, again, since like Tim's already made those points, being part of the Spark community, I mean, before Spark, we had already implemented, we had started a Fire journey. So that was based on our view on what it needs to be, and it was very myopic. If I were to say, it was always from our perspective, our vendor's perspective. I'll give an example of e-requesting. I mean, and we assume because we are, I mean, MediRecords as a product is it's a primarily as a primary care service provider, but being part of e-requesting, we also got to see labs viewpoint. We understood what they need and why they need, and an example would be an encounter. Labs need an encounter always for a request, whereas our product sometimes allows an INR request to be created without an encounter. So again, it's like the implementation from our side was from a perspective, but then when we went into these communities, these groups, we understood where they are coming from and why they need that information, and that has driven these conversations.
And as vendors, we really only want to build things once. So if we can be part of a community that knows the way that things are going to be built, that is massive for us. We get it right the first time.
Yeah, exactly. Reuse is such a valuable output. And why is MediRecords involved?
Well, it's partly that learning piece. It's partly the community piece. We don't always get the opportunity to be in the same room as government, and even some of our competitors are in the room as well. And there are benefits from our competitors being in the room because ultimately we're all consumers in the same healthcare system. So we want to be part of that conversation around how to do things as effectively and efficiently as possible.
And again, just to add to Tim's point, Matt Galetto, our CEO, has always been, he's always embraced technology, he's always forward looking, which is why, to add to Tim's point, we, some of the legacy technologies we do interfaces and all, we have not been looking at them. We are trying to look forward. And the moment we heard about a program, Spark, which will be about Australia-wide AU Core fire profiles, we jumped onto it because we are like, this is something we need to be part of.
That's fantastic. Yeah, it's good to have you on board. And from the perspective of which standards from the fire implementation guides that the community are putting together, which ones are you using in practice?
So we started off, like I said, our journey started before Spark. So we started with AU Base. We had a quite a decent implementation. We have been adding to it as well. And then once Spark started, we have started our AU Core journey. Our product's clinically coded, so we have always had SNOMED coding embedded in our product. Now we are seeing the benefits of doing that because we're able to leverage it as part of Spark, and also we were doing it before also, and also AU CDI. We are part of both CDG and TDG, where we are able to see the different kinds of conversation that happen across these two groups. Now, when it comes to Spark, there are the three projects that are running. We have been part of AU Core since day one. E-requesting, we were part of it. It's in our roadmap. So we are looking at doing AU requesting sooner into the future. And also AU patient summary is something we are really keen on because as I told you about the example and many examples that I think people have faced while traversing the ecosystem. And looking at the use cases that are being discussed, they are so relevant to the real life, and that's something we also want not only to be part of, but we also want to embed it in our product as well.
Fantastic. So now that we've all talked about it, keen to see it. Can you show us what it looks like in action?
Yeah, sure. So I've got probably I'll start with the first example that we had presented at the Adelaide Connectathon. So we have embedded the CVD risk calculator into our product. A bit of overview, since we have already got an existing set of FHIR capabilities. So CVD risk calculator being a smart app, it's leveraging that. We are able to launch it from our product, and we are able to pre-populate information, which is leveraging the existing FHIR implementation that we have. Just to add, even though we had our existing implementation started with AU based, they are all AU core compliant. We have gone through testing programs that are run by Spark, and we have been able to prove that they work. So this is so what our product looks like. So if I log in and I go to a patient's record, I'll pick up one of the patients that I have set up. So Walker Plank. So as you can see, this is what our product looks like. So what we have done is we have embedded launch of that product into our clinical tab. So here's what it looks like. So if I click on it, it effectively launches CVD risk calculator that has been created by the Heart Foundation in collaboration with CSIRO. So as you can see, if I show you the patient record, the patient name is Walker Plank, clinicians there, practice healthy family practice. There are certain conditions that the patient has. There are certain medications and also immunizations, allergies, etc. So if I go to the CVD risk calculator, you can see it has pre-populated the patient's name, picked up age. Again, this is being fetched behind the scenes using the FHIR capabilities that we have, practice owner, sex. Some of the things, again, we don't have smoking status right now, which is why I did not get populated. Age there, sex is there. Key thing here, this use of CVD medication. So it's populating that, calculating based on the medications that are listed against this patient. So it's able to decipher based on that and populate whether it's got blood pressure lowering medications or not this patient's got. So this is what pre-populations I'm talking about. There are other aspects of the calculator also that can be populated. The more we implement these profiles, the more this calculator will be able to leverage and pull in information and also push a score back, which can be basically used to calculate a CVD risk score of a patient over a period of time. So as you can see, it's one thing. It's a single product. It's a single app that can be embedded by any vendor product out there in the market. It's going to look and feel the same from a clinician point of view. And it supports interoperability because underneath it, it's using FHIR, it's using clinically coded information. So that's what's going to drive the future of healthcare in Australia.
This is pretty cool from a couple of points of view, Michael, in as much as this is the Heart Foundation working with CSIRO and working with vendors like ourselves to create a form that's easier for doctors to fill out, that pulls information in real time. But it also means at the back, you're going to have clinically coded information and a really quality data set at the end to start to do those smart pieces around predictive work and population health on cardiovascular disease risk. So this is a nice example of the different parts of the Spark community working together, singing together in harmony, if you like. So.
And just to add, this is one of the smart apps. I think there are many in the market right now, and then I mean, the future probably will be smart app driven, where rather than each vendor having their own implementation, there'll be these apps available in the marketplace where you can come and implement them and have standardization across the entire ecosystem.
Yeah, absolutely. There's huge value in data reuse. That's fantastic.
So moving on, again, this is another one of our test environments. Something else which I wanted to demonstrate is just want to show the FHIR profiles that we have. Sorry. These are the list of FHIR profiles that we have. Again, we are adding to it. So the next use case I want to demonstrate is technically it's called closed loop prescribing. Effectively, from a layman's term, it's knowing your medications request right from order creation to dispensing. So a clinician will have a view of how that's progressing. So if I go to our product and if I go and create a new medications request, suppose I'll go and create a medication sort of a Nurofen. It's triggered interactions. As you can see, ibuprofen. I won't be able to use ibuprofen. So if I go and probably create an order for Panadol. And I'll set the number of repeats to 3. And I prescribe. So what this medications order is going to do, we have created an order. It's going to trigger a medications request notification, again, which is leveraging our existing file profiles. So as you can see, it has created a webhook or a notification. Now that notification will contain all the information about the medications request in file format. So as you can see, it's the generic names there, the brand names there. It will also contain the SNOMED coding, which is what I was talking about, clinically coded information about the drug. It will also contain some of the information whether approval is required or not, act as the status of the medications request, and the relevant stuff for us is because we're talking about dispensing is the number of repeats, which is here, the number of repeats allowed. So all this information is there. And any dispensing system can listen to this information. They'll receive a notification. And as soon as they prescribe, now I'm going to simulate something using Postman because we don't have a medication system hooked up. So what I need is I just need the ID of the medications request. So I'll come and fetch this. So I've got this ID. If I go to my Postman, I can set the number of repeats. Suppose only one repeat has been dispensed. So I can go down, I can set the medications request. Again, this looks technical, but this is all about implementation. The end user will never even see this. So if I go back to our medications request, we also implemented workflow. So as you can see, it's showing that it's pending approval because there was an approval workflow. It's also pending dispense, and the number of repeats is 3 for this medication. If I go, and what I'll do now is I'll simulate sending a dispense notification. So your dispensing software could be a Fred. They'll dispense the medication and they will basically increment or decrement the number of repeats, which will reflect in the system. So I've done that. It was successful. I just come here and refresh my medications. It shows dispense, showing that the dispensing software sent us a notification and said, yes, we have dispensed it, and the number of supplies. So yes, we have dispensed 1 repeat and there are 2 pending. So that, like I said, it looks, probably I demonstrated it in 2 minutes, but there's a lot of stuff going on under the hood. Creating the patients, we are creating patients via FHIR. Creating medications requests, we have implemented the FHIR medications request resource. We have an encounter, as you can see, the consultations running, which means it triggered an encounter. For the context, there are the indications, counterindications were triggered by allergies and conditions that have been set. Each one of them will also send notifications. We have implemented FHIR immunization, FHIR allergies, FHIR medications, and allergies profiles. And all of these, our vision is not vision. I think it's going to happen soon. Not even called vision, will lead to patient summary, which is what Spark's working on also. So these are the sort of the ingredients of the recipes of the final product that we'll deliver, which is patient summary.
Great. So the final goal for you at the moment is the patient summary implementation guide, and then the others, they're on your roadmap as well in terms of e-requesting and the use of AU Core across many applications.
Yeah.
That's great.
Absolutely. And, this is a great example of AU Core being the foundations for information that really increases patient safety wherever they are in the system. So this is a big part of the work we're doing with the Defence Force around real-time data exchange as well. So it's very exciting to see sparked initiatives coming to life in the real world.
And just to add, I mean, this is our product. This is what it looks like. Our data model might be different from, say, a best practice, but at the end of the day, we are leveraging FHIR for information exchange, which is going to ensure all these vendors, any product, any ecosystem, able to talk to each other in the same language, like Tim said.
Absolutely. And why should others get involved in Sparks? What would be your advice?
I think for me, top of mind is that that build piece. So that make sure that you are building on the right foundations. You're building something that's useful and interoperable with the rest of the Australian healthcare system. And you're part of a community that is welcoming and warm and supportive, and hopefully, leaving the commercial agendas at the door and say, we actually have an opportunity to fix things here, to build something that's useful to all of us as consumers. So for us, that's kind of a no-brainer.
And just to add to Tim's point, we had started a journey before Spark. We had some assumptions. We started from our perspective. It's been really eye-opening being part of the Spark community, where we have so many different perspectives, learning from different players, different stakeholders, and that's really important, so that we don't end up making the same mistakes that we did pre-Spark.
Absolutely. And also, I think another thing that's I'd add is the value that I've seen that you've gotten out of, and also others have gotten out of joining the Sparked Connectathons to effectively test your products against the standard to make sure it's fit for purpose and vice versa.
You've hit the nail on the head, Michael, and effectively, and the way these events are structured, the sparked face-to-face online meetings combined with connectathons and the testing events, it means not only we are having consensus-driven conversations and discussions, we also testing them. So it's not just theory; it's all vendors then sitting together and testing the what do you call the theory. So yeah.
And typically, we would mostly have exposure to primary care in the work that we do, but this brings into the room aged care, disability, and other, aspects of the healthcare system, including consumers. So it's important that we listen and we learn and we learn together.
And just to add, I mean, we have the agency and government representatives there as well. So they also get to see our side of the story, and we get to hear their side of the story as well, and can have a robust conversation about these issues and find a way out. Yeah.
On that point, Tim, around, I guess, insights of adopting these national standards, what would be one key lesson or learning from your experience so far that you'd suggest to implementers?
Look, the one that I'm most excited about, the initiative that I'm already kind of advocating for when I'm out and about, is the international patient summary, or the shared patient summary, because I believe if we have one format for data for patients wherever they are in health in Australia, we're going to save lives. And so I've seen, my wife was in ICU for a long time, some years back, and our GP was scuba diving somewhere. So it was the only way we could get a record of her medication history was the fact that I had access to her My Health record at the time. And for me, it was a real wake-up call as to the importance of data in the moment, because you don't know what's around the corner and whether someone's going to not be able to speak for themselves. So for me, it's an opportunity to be part of saving lives by making the right information available at the right time in healthcare. So, we're very committed to being part of that conversation.
And from your perspective, I guess I'm keen to know, from a technical perspective, what are the, I guess, insights that you found valuable from, I guess, implementing standards?
I'll defer to Sanjit on that because I'm not a technician, but for me, I know I keep using metaphors, but we might all be coding in the same language, but we're not necessarily using the same dialect. And so if we want a GP product to talk to a hospital product to be available in the My Health record, we need to all make sure we're speaking the same language. And so I do apologize for maybe oversimplifying, but that's the way I see it.
Yeah, just to add to your point, then probably SNOMED might be the best example. I can talk about FHIR as well, but SNOMED, it's like it's coded, it's universal, it remains same no matter who's leveraging. So whatever we have in our product, our clinical information is SNOMED coded. So what we're pumping out via FHIR profiles is universally acceptable and readable. And that makes a huge difference rather than having these transformation happening at source and destination, which is really inefficient from a data transformation point of view and also from a maintenance point of view.
Good data in, good data out.
Yeah.
Absolutely. We were all about data quality here.
Yeah.
So with that, thank you very much for your time, and I really appreciate all of your contributions from a community perspective. We appreciate your good corporate citizenship. And for those listening, if you're interested in participating in Spark, we've included a QR code that will take you directly through to registering, but also feel free to jump onto our website to explore and have a poke around. We've also got a Spark podcast. Season 1's out for those who are interested, and we're currently working on season 2. And we also share a lot of information and updates on LinkedIn as well. And lastly, if you have any questions, you can email us at sparked@csiro.au. And with that, thanks very much, Tim and Sanjeet. Appreciate your time.
Thanks
Thanks
Mark.
for having us.